So let me make it even more difficult. Combination regimens. All right, let's lard some stuff on here. You alluded to this with renal cell cancer. Typically seen as the best route to treat cancer in the past, how are combinations, including immunotherapy, impacting resource allocations?
Well, I would think of combinations with immunotherapy a little bit differently than the way we've thought about combinations with traditional therapies, such as chemotherapies or targeted treatments. And in that, it gets back to what Jeff alluded to, that there is whether it's a single dose or there's a series of dosing that happens, and then that's a treatment effect that then is subsequent to that. So you could think of combinations with ipilimumab as happening after the ipilimumab is done, whether it's radiation or chemotherapy or other strategies. Same thing with Provenge. I'm not sure we necessarily have to think of combinations in the same context as what we thought of before. Now, there are targeted therapies that don't work that way. They work as long as the drug is on, and when the drug is off, they stop working. So there, the combinations do have to be synchronous. But immunotherapy, that is not that paradigm. So it gets back to how we think about this, not in terms of its upfront cost, but as the cost over the lifespan of that patient, and all the subsequent therapies as being, in a sense, combination.
Well, it sounds complicated. Is there an evidence-based method for determining this cost-benefit ratio for the various possible combinations? Do you see one?
I'm sure there is, but that's not my area of expertise.
Although, to be honest, again, tomorrow morning you'll hear about the first simultaneous combination of PD-1 and IPI. And the abstract's already been published, and there's been a press conference about it for ASCO already. So it's got a pretty high response rate, between 40 and 50%. Fair bit of toxicity, 50% dose-limiting toxicity. But those patients, you know and I know, are going to live a long time. So that combination is now being developed in phase 3 studies already. So survival, durable responses and survival is going to be the endpoint. And those endpoints will probably show that there is a benefit to doing some combination of immunologic therapies. Mm-hmm. The question is, if IPI is $140,000 a year for the wholesale price, God knows what PD-1 is going to be. What if it's an equal cost? Actually, the PD-1 you keep using it's every other week for multiple weeks. What if it's $300,000 a year? I mean, can we afford that? I don't know. That's a tough one.
Brings me back to Mike. Can you think of any examples of cost effectiveness or quality of life data that are available right now to aid in the decisions on this issue, this coverage and reimbursement?
As we discussed before, that has typically not been the
Is
process.
it just because it's politically unpalatable?
It's part of that. I think the quality of the data is poor. I think it's more than just that, but it is a difficult pill to swallow.
Is it reasonable to dilute everything down to money anyway? I mean, are we underestimating the benefit of therapies when you say it's just the cost of life? It's just a dollar and cents equation.
No, listen, if a medicine got invented tomorrow to cure cancer, people would get it. I mean, I think we would, as a society, decide it was worth it, irrespective of what the price is. You know, I think the kind of the elephant in the room is, why do things cost so much money, right? We've heard the excuse that drug development is expensive, and maybe that's right. It's not my area of expertise, but why do things cost so much money? Are we going to get at the ultimate cost of developing a drug and what a fair price is? Is the government going to step in?
Part of it's because so many drugs fail.
Yeah, that's what they always say.
I think that's true to some degree.
We will see what, I don't know where the truth lies. I don't know, but all I know is this: I don't think it's an accident that everything costs $10,000 a month now.
Yeah, it's
right. It's just not. I mean, you said it yourself. It's what the market will bear.
Right. Yeah, and when you talk to drug companies and say, how do you set the price? Why do you set the price so high? They'll come back and say, we have to.
Why?
We have to.
Why?
Just like Mike says, it's not his money. He's really just being a steward. They're stewards of their shareholders, and their shareholders will come back and sue them if they don't price that drug at what it maximally could be priced at. And that's our capitalist society that we have.
But I mean, that's been changed though, right? I mean, there was Zaltrap, right, which came out at X number of dollars, and
right.
and then Sloan Kettering, right, said we're not going to pay for it, and the price dropped.
Yeah, it's a very simple solution in the capitalist system. If nobody wants to buy your product, it doesn't matter how much you charge, you're not going to make any money.
Yeah.
But if you drop the price and then people start to buy it, then you might make some money. That's just the way it goes.
Yeah. But we're going to see a very interesting thought experiment play out over the next 18 months with TKIs in chronic myelogenous leukemia. So, as all of you are aware, recently there was an article in Blood where the CML researchers went out there and said, look guys, you know, these drugs are really, really expensive. We're not sure why they cost so much more money. The new ones cost more. They have small incremental benefit. So what's the thought experiment? Imatinib goes generic in a year. Imatinib goes generic in a year, which means that we're going to have drugs like dasatinib or nilotinib that cost $8,000, $9,000, $10,000 a month, and we're going to have imatinib. And I don't know what it's going to cost. Let's just argue $1,000 a month or $500 a month. So should we step? Should we require people get imatinib first? Is there a reason not to do that? So now we have this scurrying going on about trying to define the value proposition for the newer TKIs. Yes, they're better TKIs. The depth of response is better. It's got a better molecular profile. The question, though, is not that. The question is, if you start with imatinib, is there any risk to the patient of doing a step?
Well, let's make an economic argument on the other side, if you will. Take a look at Provenge. Right? It resulted in fewer hospitalizations. The number I've got is 1.2% versus greater than 26%. Right? Fewer discontinuations, fewer deaths than AEs with doxycycline and prostate cancer. So you can make the if you want to make a dollar and cents argument with some of these drugs, Provenge, for example, is a propositus, you can say it's going to save money compared to traditional therapy, and you're only going to put that in once.
Oh, people don't get either or. I mean, talk about disingenuous. People know that there's a lot more toxicity of chemotherapy. People who fail Provenge get chemotherapy later. I mean, it's comparing apples and oranges.
But
it's not the right question.
But take it the other way around. People who do well on Provenge don't, and then it may be much more than cost effective. No? Dan?
The benefit to Provenge is the same whether they get docetaxel or not. The clinical trial that was done, these were clinical trial patients in the US, and only 50% of them went on to get docetaxel chemotherapy. When that was really the only other approved therapy at the time for advanced prostate cancer. So I would just push back on Michael a little bit. I'm not sure that everybody's going to get every therapy with prostate cancer or even kidney cancer. If you look at our registry work in kidney cancer, 20% of patients have third-line therapy. So there's a drop-off with each of these. And some of that is disease progression and death. And some of that is patients don't want any more therapy. You know, and there's, you know, so I think there's a lot, again, there's heterogeneity in this field and everything. And I think moving some of these therapies up, particularly immunotherapies, that have demonstrated their greatest value, if you will, in the long-term survivors, to me makes the most sense. If you're going to use those treatments, use them in a setting where we have the potential in that patient to live long enough to really get a more absolute benefit, whether it's due to sequential other therapies or not.